When you are ready to begin the presentation, press the Start Broadcast button on the GoToWebinar control panel to allow all attendees to hear you. This system will notify you once you begin your broadcast. The
Testing,
broadcast
one,
is
two,
now
three.
starting.
Testing,
All
one, two,
attendees
three.
are in listen-only mode.
Testing, one, two, three. Testing, one, two, three.
I'm sorry, I'm unable to take your phone call. Please leave a message. I'll get back to you as soon as possible. At the tone, please record your message. When you've finished recording, you may hang up or press 1 for more options.
Hey, Jared. We're meeting at 8 o'clock with Dan Warren, from Research Coordinator at Langone at NYU, and William McCauley, orthopedist at Langone and NYU. The proposal to be to ally with New York University Langone as our first university that we ally with. So anyway, that's our meeting coming up at 8, and then 9, International Cardio-Oncology and International Cardio-Orthopedics, and I'll talk to you when I talk to you. Bye. Hello, Dan. Good morning. Hello, Delina. Good morning. Hello, hello.
Hi, this is Daniel.
Hello, Dan. Can you hear me?
I can hear you, yes. How are you today?
Hello, Dan Warren.
Can you hear me now?
Let me adjust my sound. I don't think you can hear me.
I can hear you, but I don't think you can hear me. So let me.
Here we go. No, I couldn't hear you. Good morning,
Can you
Dan.
hear me?
Yes, I can hear you now.
Hi, good morning. Can you hear me?
Yes, I
Awesome,
can.
great.
How are you? Dan,
Good. How are you?
I understand you're the research coordinator there.
Yeah,
Is that correct? What kind of projects do you have?
that's correct. Yeah. So, we've got a lot of interesting stuff going on. Mainly a lot of society and like hip society and AUKUS. A lot of
Yes.
multi-institutional projects that are more small scale. So it's interesting.
Yeah. Good. We're gonna wait for Bill.
Yeah, he should be joining here soon.
Okay, great. How's the weather in New York today?
This morning was nice. It's like 50. It's supposed to, that rain is supposed to come in late this afternoon, so we'll see.
Yeah.
And where are you based out of?
Tampa, Florida. You'll
Nice.
want to coordinate our research in February.
Yep, I'm from Miami, so
Oh
I
yeah.
just actually moved up to New York in December, so
Oh my
it's been a
goodness.
change.
Must be tough on you.
Yeah, it's not too bad. I mean, it could be worse. Could be Chicago, right?
Yeah,
Or Milwaukee.
you could be back in Florida in a year or two.
Yep. So I just texted McCullough to see what his status is.
Great. Thank you. Are you doing anything with pre-op risk assessment?
I just started in December, so I'm still kind of getting the hang of everything that's going on, but I don't think so,
Yeah.
but it doesn't mean that we aren't.
Hello, Jarrett. Good morning.
Good morning. How are you this morning?
How are you, Jarrett? I'm very well. We have Dan Warren, who's a research coordinator at Langone, research coordinator who's on right now, and then we're waiting for Bill McCauley.
Fantastic.
Yep.
Hi, good morning.
Morning.
Jarrett's our COO.
One moment, I'm going to move to another location. I have a sleeping baby here.
Oh, yeah. Be careful. Hello, Delina. Good morning.
Morning, doctor. How are you?
I'm very well. Yourself?
Very good, thanks. How's Tampa today?
Tampa is very pleasant. Very pleasant.
Good luck with your webinar.
Welcome to our webinar this morning.
Thank you. It's nice to be with you.
Yeah.
McCauley said he needs an audio pin.
Let's see. He has to log in to get an audio pin. He's not logged in yet, so I can't give him a pin. Could you advise him to log in first?
He might be traveling and not able to pull it up on his phone.
Oh, okay, because he has to log in before he can get the pin. Because I have to click on it, and I don't see anything to click on.
He says he can join listen-only mode.
Listen-only mode. That's weird. I'm not sure what that mechanism is. I'm not sure why that is. Because you joined in the same way that he would be joining, correct?
Yeah, but he may, like I said, he may be on the train or something and unable to pull it up from a desktop.
Okay, well, I don't have him even logged in because he would come up on my screen. So he's not on my screen at all, so I don't know how he's logged in. But we'll wait for a signal from him to begin. So if you could keep in touch with him.
So he can hear us. Yeah, he can hear us.
So he wants us to go ahead and start?
Let me just text to make sure.
Okay.
All right. So yeah, let me try to give him a call first and see if we can figure this out, and then I'll come back onto the line. Okay?
Yeah, so he should just log in just like you did.
Okay. Yeah. So let me give him a call.
Okay, great.
I'll be back.
Okay.
on the email it says number one, it has a blue box that says join webinar. If you click that. It's 7:21. Yeah, we got one yesterday. We got.
Delina, if you didn't notice, that's Beaumont.
Yes, I thought I recognized him. I like that.
That's the intelligent Beaumont.
With the glasses.
So then once you click on that, then it says you have to install something quick. Take any time at all, and then it brought up the screen. That's how I got it. For us to hear.
I sent a PIN number, an audio PIN number to Bill.
Sorry for the delay there.
Hey, Dan, I've sent an audio PIN number to Bill.
Okay, he was able to log in. He's at his desktop now, so.
Okay, I'm waiting for him to get his audio PIN number. It looks like he's logging in. Hello, Bill.
Yeah, he said he was able.
Yes, I'm on the line.
We've got you. We can hear you, Bill.
Okay, that's good.
So we're going to go ahead and start. I introduce Jarrett Moore, who's the COO of Private Cores, Delina Fries.
Good morning.
And we've got
Good morning.
Delina Fries is my sponsor for Rollins College for an award there. And she wants to find out something about what we do. And we've got Dan and Bill. And Dan is the research coordinator. And Bill is a very active orthopedist. And all friends of Richard Diorio. And so,
Correct.
Correct. So we're gonna, and Jeff Berger has a separate appointment for our conference call. So that'll be later on in March, around the 16th. I'm Eric Harrison. I'm a cardiac imaging specialist, and we'd like to introduce the Langone Orthopaedic Group to something called cardio-orthopedics. And we hope we can pick your interest where you may be interested in doing a registry with us. And so we know a lot about what you do there. I work with Langone on at least a weekly basis with Didier Lemay, who does surgery that's robotic. And so he does mitral valves for me, and he just finished a patient, and then he's got another one coming up there. So we've worked together for a long time. And so I'm very familiar with Langone and the things they do there. And Delina knows about the quality because she spoke very highly of New York University Medical Center. And so we'd like to introduce you to cardio orthopedics. I founded something called cardio oncology about 7 years ago, which has been, we had our global meeting of 350 doctors in London last year. We're having our meeting in Tampa this year. It's been very successful in integrating oncology with cardiology. So we hope to do the same thing, and we'll show you what our mission is, and hope to get some interaction and some thoughts from you. And feel free to interrupt at any point. We'll try to sort of make our way through at 30,000 feet, but sometimes we'll swoop down, and if we swoop down too low, let me know. So this is
Okay.
Beaumont, who's a therapy dog, and we thought we'd show you our mission, which is we started doing some very advanced cardiac imaging in 2004, and basically set up cardiac CT and switched over from nuclear medicine and from stress testing and from cardiac cath to cardiac CT, which has been very successful, and we've accumulated 5,000 patients over that period of time in that data, and we follow those patients longitudinally, and we use that to create an analysis of plaque in coronary arteries that's predictive of whether someone's going to have a heart attack or not, and some time frame, and we call that the Sherlock program. And we also interact with a supercomputer in Palo Alto that gives us information on the blood flow, and we can get that in a period of a day or so when we just click on the keyboard, and that information goes to Palo Alto. And so this leads to the recognition of who's going to have major adverse cardiac events. And so we decided we would approach, and we'll show you why we decided that we would approach the orthopedic patients. So why cardio orthopedics? And basically this is sort of our premise that should tell you quite a bit. And basically silent heart attacks, atrial fibrillation, hypertension, LVH are all complicating factors that occur in orthopedic patients at some point, perhaps, especially with those over the age of 65. Some patients that have a history of adverse cardiac events in the past, and so on and so forth. This results in the bundled patient having higher cost, and atrial fibrillation cost a patient $20,000. Didn't really cost the patient, it cost the insurance carrier, but if it's a bundled case, then you've got a problem because you exceed the reimbursement of the United States Medicare. So it costs $7,000 if a cardiologist touches a patient, and that's what it costs the system. The cardiologist doesn't get the $7,000. And we think these costs and these risks can be predicted and contained, and we think that where the cardiologists have gone awry in the past has been using and relying on stress nuclear and stress echo test, which have Blue Cross Blue Shield did a study in Michigan. There's a 40% false positive, 65% false negative. And so with the advent of coronary CT, we think we can be more target specific, and we can predict. And so we'd like to show you a little bit about that and how we've done that. So prediction, not narrative, is the real test of our understanding of cardiology from the Black Swan. And so this is where we've evolved with our detection of atrial fibrillation. Our Sherlock program of CCTA analysis was a presentation to Dr. Bernasek and the group from Florida Orthopaedics, and then moving up into the Lower Extremity Care Redesign Committee, the Adult Recon Weekly Conference, and then starting our pilot project November 1st, and then culminating in a presentation last month of the first International Cardio Orthopedic Academy webinar. And we're going to follow this presentation today with a presentation by one of our Polish colleagues. And so, and today is we think this is a hallmark to be presenting to New York University, where I have a lot of patients that are going currently in the cardiac realm. And so we thought we'd tell you that cardiovascular is the number one cause of serious complications. It used to be DVT and pulmonary emboli, and it's not anymore because we've been very successful in containing that. And so we think that we need to refocus. And so we looked at our 5,000 patient database, and these cases popped up quite regularly, where we saw problems with coronary artery disease, problems with atrial flutter, problems with atrial fibrillation, problems with hypertension. All the hypertensive patients had left ventricular hypertrophy, which means they were inadequately managed. And so that was very interesting to see that those are, we call them bundle busters. Those were bundle busters. And so we'd like to share some of this with you. And so we looked in the literature, and they had the same conclusion, that it seems to be atrial fibrillation, and it seems to be myocardial infarction that seems to be causing a lot of trouble. I like the way they presented this and said there is no increased risk of in-hospital mortality and complications, except for myocardial infarction, as a little aside. And so we looked at the American Academy of Orthopaedic Surgeons, and they certainly have done a great job obsessing with DVT and pulmonary emboli, with 183 pages of guidelines for DVT. I've got it on my iPhone, and but I, now that cardiology is number one, I'm not proud of being number one, but now that we're number one, I'd like to say that we need more guidelines, because there's only 2 pages of guidelines, and those pages are here, and the pages are pretty vague. They say, well, if patients have known risk factors or known coronary artery disease, they might have some problem. And so, no kidding. And so then they talk about history of a cardiac event. The same thing for the knee. They don't tell you how to do this or what to do. And so I think the guidelines really fall short. And perhaps you in the orthopedic area and arena can help me reshape the guidelines. And I think that's our ultimate motive, is to get this out in the public. And so we'd like to say that cardiovascular complications do stand up as being number one, and apparently cerebral vascular accidents as well, which I think that's atrial fibrillation. Pulmonary emboli has really slid thanks to the diligence that the orthopedists and their group have had. And so, but 8 identified big studies have shown it's a leading cause of death, and so on and so forth. And here's a quote down here from Richard Oriol and James Slover, an article that they wrote recommending certain things, and probably your team. And then this is the Goldman criteria for risk. And the risks are pretty obvious there. Congestive heart failure. We don't see a lot of people that come dragging in like this. They come dragging in because of their leg or hip or knee, but they don't come dragging in because of these problems. And so we're not seeing a lot of these. And there's a Canadian score as well that is pretty much the same, except it relies on pathological Q waves, which I would never want to do that. But it looks like in totality, troponin goes up when you have surgery, and this is the time frame, and troponin's a marker of myocardial ischemia, either type 1 or type 2, and it looks like 1 in 7 people are having a troponin elevation. And here's a reiteration of the same thing: 1 in 7 patients having positive troponin, which means some kind of injury, or left ventricular hypertrophy, or thickened ventricle. Doesn't have to be a discrete myocardial infarction with all the signs and symptoms and EKG change, but it can be something going on cardiac-wise. Even transient atrial fibrillation can boost the troponin. And so Christian Mueller has written a lot about this, and you can see troponin blip is common post-operatively in a lot of people over the age of 65, and of some concern. And it does symbolize, if you have a silent MI, you still have some mortality and congestive heart failure problems as the patients who have clinical myocardial infarction. So it's something for us to be concerned about. So the question is, what is unique about total joint arthroplasty, and what do these patients contribute to gaining cardiovascular complications, other than I've looked at a group over the age of 65, and other than the fact that they're bundled? And so for me, years ago, I was doing a transesophageal echocardiogram about 30 years ago in the OR on a patient who had an LAD lesion and was getting a hip. And I was very concerned that she would get ischemia during the procedure. And so I wanted to be able to monitor that, and that's why I was doing the TE, and I was going to give her IV nitroglycerin if she had some wall motion abnormality. And all of a sudden, we see this snow flurry coming into the right atrium, right ventricle, that I was totally unaware of. And it totally opacifies like you're injecting a contrast. And so that was very startling. And the orthopedist who was hammering away down there looked up and observed this and said, "Turn that damn thing off," because he thought it was very dangerous. He was thinking it's fat going in there. And so he was worried about the patient. So he didn't want to see it. It's out of sight, out of mind. But this is bone powder. And the bone powder, we can show you a little picture. Here's the bone powder. It's little pieces. This is a biopsy. And it's little pieces of stuff that's got fibrin attached to it. And it's a very strong platelet activator, as you will see here, in terms of. And we are hoping we can interact with Jeff Berger, who has a platelet lab. And unfortunately, he couldn't be at this presentation, but we're going to talk some more. And that's one of the reasons why we have selected Langone to interact in, is basically Jeff Berger's platelet lab, because we think this is pretty important. And we think this is activating platelets all over the place, and that this platelet aggregation and hypercoagulability is leading to part of our problem. And so let's look at the patient then. How does the patient as a substrate interact here? And the patients do. It's amazing when you start talking to somebody, and I'm seeing them every day now, who come in who've got a hip or a knee problem. And it took them actually 6 years to get there because they were chicken. And so, they got the injections, they got the steroid for a while, they got, some of them paid $7,000 for stem cells, and all this stuff they've gone through. And finally they show up and they say, well, I'm going to get my knee done. Of course, after they get it done, they say, why didn't I do that like 4 years ago? And so by that time they have a sedentary lifestyle, they have obesity, they've gained maybe 15 pounds. They've not walked a mile for a long, long time. Their blood pressure gets away from them. They get thickened left ventricles. Most doctors seem to think that giving one pill might take care of hypertension, but 60% of people need 2 pills, and we see those people all the time, and they have left ventricular hypertrophy because they're inadequately treated. So we got visceral fat, obstructive sleep apnea, and then atrial fibrillation pops up with all these things, and then somebody goes into surgery in this kind of condition, and then we activate clotting factors. So, and then from there on, there's a greatly increased risk of cardiovascular, cerebral vascular events, but declining over a period of weeks and the outcome turns out good, because a year post TJA, basically you have it decreased over the normal population of cardiac events. So you've gotten active, the metabolic syndrome's gone away, you're really happy to be able to walk again, and so your life changes, you drop some weight, and you're back to doing very well. Actually, you're doing better than you were before, and certainly better than your cohorts. So there may be an increase in coronary artery disease. Here's projecting in this age group by 20% among males, and actually what's been found is 27 to 32%. We'll find this out ourselves and see exactly how they're classifying those people as having cardiac disease. And so, well, here's a nice patient who had a knee replacement, and you say, well, that doesn't look too nice. Here's a totally occluded right coronary artery and multivessel coronary artery disease and some really skinny vessels. And here's a little aneurysm, and all this stuff looks terrible. But this patient went through surgery fine. There was no problem at all. And he was dealt with after the surgery. So what's this all exciting about? Well, who cares? What's the deal? And it turns out the deal is something else. And we got to find that something else. And we found what we think is that something else. And the something else is a plaque ulcer. This is a very deep plaque ulcer in this patient, where we micro enlarged to macro, the lumen. This is the lumen of the vessel. A little of the red is necrotic core, and the blue is some fibrosis. Sometimes yellow is calcification if it's a deep yellow. And so here's an ulcer, and here's an ulcer in the carotid. This is an ulcer in the coronary artery, and these are my activated platelets. They're hitting for the ulcer. There's an ulcer in a carotid also, and you can see it's sort of got some increased velocity in it. And so, again, we come back to the same premises: silent heart attacks, higher cost, predictable and containable. And so what is this cost? And certainly CMS has set an awareness of factors associated with outlier cost will be requisite to remain profitable. Well, everybody wants to be profitable in this bundle program. The government wants to be profitable too, because it's the only successful program the government has really had in saving money in healthcare. So they want to show this as a showcase. Well, we decided we would do a vascular workup of patients preoperatively as a pilot project and see what we could find out. And so you can see we're going to keep this under $1,000. And so we'll be reiterating what we're doing in terms of looking at the carotids, looking at the heart with an echo, and looking at the CT scan and maybe a couple markers. But let's show you a case that went bad. And so here's a 77-year-old guy who had a right hip in the past. He's going to get a left hip, and he's got complicated cardiac history, but this would be called stable coronary artery disease. And believe it or not, with all this stuff, it would be called stable and low risk. And so, okay, well, let's see. He doesn't have congestive heart failure. His EKG, it shows an aortic infarct. Yeah, that's there. And, but things look pretty calm. Never had a stroke, didn't have atrial fibrillation, and so forth. And so let's see what happened to him. Well, we thought he was low risk, but guess what? He went into atrial flutter. He got anticoagulated. He bled into his hip. He dehisced his wound. He got infected. He had a clot in the leg. And, wow, rehab. This guy came to my office, and he had horrible experience. And he went over the cost. It's going to be a biting cost of $21,000 over. And so with the cardiologist having the attitude of let's treat the heart, don't worry about the hip, we got to save the heart, which is not a very good attitude. And we don't take that attitude in cardio orthopedics, although we did rank orthopedics second over cardio. It could be orthocardiacs, but anyway, we feel that. So, hey, here's a low risk patient, left hip replaced, and it was a disaster. I mean, what could we have done different? Well, there's lots of things we can do different. They couldn't convert him to a normal sinus rhythm within 12 hours and have a very low chance of having an embolic episode. We could have prevented it and tried to detect it. Didn't even think of it. The guy never told you anything about palpitations, but he must have the substrate. So, and then post-op cardioversion carries with it a little bit of a hazard. If you get within 12 hours, you still have 0.3% chance of having a stroke. A 1% chance with 12 to 24 hours is not a good thing. So obviously you'd have to do a TE cardioversion, look, see if there's any clot in the left atrial appendage. And so, but let's look at somebody else then. And let's say we're going to think about this now. And the patient's not going to be the sacrificial lamb. Let's see if we could figure out how we can avoid this. So here's a nice guy who's 68 years old. And he didn't have anything except he had atrial fib 12 years ago. And he went to get an endoscopy. He's going to get his hip done. He went to get an endoscopy for some other reason because he had some dyspepsia and GERD. And basically, he was in atrial fib. So they sent him over here from MacDill Air Force Base, where I see a lot of patients from SOCOM and CENTCOM. And so he had a normal EKG, a normal echo. Everything looked pretty good. He was low risk by the Charlson risk score. I don't know how anybody keeps using that. It's from 1994, but we'll talk about that later. But anyway, we did find he's having episodes of atrial fib. Obviously, if he went over there for endoscopy, and we found that out. So he said, we can contain that easily. And so what if he has coronary artery disease too? Well, he doesn't have any symptoms of coronary artery disease. What does that mean? And so let's take a look. Here's that Charlson score, and there's Mrs. Charlson. And 1994, nice looking lady. And she's got, these ideas that are pretty fixed. I can't modify except congestive heart failure. I can get them out of heart failure, but if they have a history of congestive heart failure, there's nothing I can do about changing their history. And so, except maybe the intern missing it. And so here we go. I can't change any of those. I said, well, let's look at some risk factors that we can assess, and let's look at risk factors that might be modifiable. So then, being a fan of the Buccaneers, we said, hey, we can basically use this information and see if we can come up with a modifiable score, and that's what we're working on. And so these are the things we're looking at, and these are the modifications. And so we did find, of course, this guy having recurrent atrial fibrillation and blah, 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 and use this Zio, which is a little Band-Aid-like thing you pop on. You don't have to have all those wires and monitors and carry a box. And so the patients love that. And then we get the information. And so that's pretty handy, and we use that a lot now. And so let's look at the coronaries then. And unfortunately, we've come down from 30,000 feet, and I hope I don't bore you too much with looking at this little stuff. But there's a lot of little shit that's important here. And so we'll show you this is a lesion in the coronary artery. And we can look at that and tell you what it looks like and how it pops around and what's going on inside there. And we can see the calcium, and we can see the contrast, and we can see other stuff in there. And when you go inside, you can see the narrowing of the lumen in this particular LAD lesion that's in the mid-LAD. You can see a little lipid lake there. That little red thing is a lipid lake. And the blue is fibrosis. And, of course, the yellow up here, the bright yellow, is calcium. It's not obstructing. There's calcium up there. And then we can actually look at the shape, and we can say it's a convergent divergent double cone, which is like a rocket, which has Navier-Stokes equations that we use. It's computational fluid dynamics, which is pretty cool. And then we can display this whole thing, and here's our convergent divergent double cone. And here's a little indentation that represents the lipid lake. And here's the amount of myocardium at risk, which is a big hunk. You can certainly say that. And here's the ulcer, a plaque ulcer. Here's some platelets heading in that direction. Say, oh, there's a nice ulcer. And then here we're looking at it here from three-dimensional inside. And there's that little ulcer that's 1.2 by 1.8 right there. And there's a piece of contrast there. And then we look at blood flow going down the artery. And, since we put contrast in there to make a picture of the artery, you can see how much contrast is in the myocardium distal to the lesion. And so we're looking at contrast distal to the lesion, and we can see there's less iodine subtending the lesion here, which basically represents the LAD lesion. And then there was a lesion in the posterior descending down here that we didn't tell you too much about, but there's a lesion underneath in the posterior descending, and that's accounting for some decreased iodine as well. So we get two coronary lesions, but this is the most interesting one because of the ulcer. And this is something called speckle tracking strain echo. I don't want to bore you, but it's decreased activity here in the anterior wall, which has to do with that LAD lesion. Here's a hunk of muscle, and we can actually calculate the blood flow based on what we have here. And a hunk of muscle again. This is all 3D. Well, you're seeing flat stuff. I don't like flat land. Everything we do is 3D. And so there we go. We look at all this stuff, and it looks pretty nice. And we line everything and come out with some information that's pretty interesting. And the information is, we say this guy is going to have a heart attack. Here's where the students actually get some of these things. They're going to pair up the ulcers with how long it takes to have a heart attack, and pair up the plaque as well. And so they're pairing these things up and showing how long it takes to have a heart attack. And so there's a little plaque ulcer to show you what it looks like. And you could do angioplasty and stenting, but unfortunately we can't. And why can't we? I'd like to angioplasty and stent that thing. Not that I do that, but I'll get somebody to do it. And unfortunately, the guidelines don't fit that from Europe or the United States. And so they say it's uncertain about the complications and about doing this to avoid untoward perioperative events. That putting a stent in is not certain thing. And they say this is a intermediate risk surgery of the hip, 1 to 5%. That sounds pretty bad to me, but intermediate risk. And they're looking at preoperative testing, and they suggest a stress test that has the 40% false positive, 65% false negative. That's where you went wrong. And they're looking at who should you do a stent and who should you not do a stent. And they have these guidelines, and the guidelines say no. Routine, prophylactic, myocardial revascularization, low, intermediate risk surgery, it's a no-no. And so we got a no-no in the United States, and we got a no-no in Europe. And so, but when I look at these things, this is what I think. And I think long-term prognosis, and I got the decades of life, and I got what's going on inside here. And as we start out with the genes and lipid pool and inflammation, arterial wall, microbiota, and macrophages, we get into necrotic core, fibrofatty, fibrotic, and calcified. All this stuff is going on the micro level inside those vessels, and this is the danger zone, usually in the mid-40s, late 40s, early 50s, and then you start calcifying and fibrosing stuff, and then hopefully you wind up over here, which is a better place than winding up over here with main left coronary disease. So most people do wind up over here, especially in Tampa, Indianapolis, they don't seem to. We saw a lot of people that were actually over here up in this area. And we can show you, we made our little thing here. And this is our little plaque meter, plaquometer, whatever you want to call it. Sherlock score of plaque metrics. And so we look at this and we made it into like a protractor. And it looks like something I might see on my boat that'll tell me how fast I'm going or which way to go. And so, and here's where we got red stuff is bad, blue stuff is good. And here's our patient. Our patient at age 68 has a plaque ulcer. He's going to receive some activated platelets, not by desire, but as part of his hip surgery. And we're looking at the convergent divergent double column, the lipid lake, and we're also looking at the degree of stenosis of the diameter. And so this is adding up to get to the point where I'm predicting this gentleman is going to have a heart attack. Whoa, you know. So I'm betting the farm on this one. Not only am I betting the farm, I'm betting the farm in a big way. You have to realize I've curated, thousands and thousands of plaques, and basically 5,000 patients amounts up to a lot of plaques. And so we're predicting a heart attack in the patient. So we called the guy who's going to do the surgery, who's Tom Bernasek, head of orthopedics at Tampa General, head of orthopedics, and we called him up and said, Tom, we want to move your patient over here where we can monitor him in a small boutique hospital, and we can have a navigator, and we'll change the surgeons to somebody else in your group. And he says, gulp. Why are you going to do that? Well, he's going to have a heart attack and he's going to have atrial fibrillation. Oh, okay. Well, go ahead. And so there's a lot of faith there. And so we bet the farm on this one and say he's going to have a heart attack, he's going to have atrial fibrillation. We'll prevent the atrial fibrillation, and then we'll rescue him from the heart attack. So that was our proposition. So this was the first time we went on the ledge. Not the first time we got on a ledge with orthopedics. And so we have our nurse navigator that we trust implicitly, who's going to be keeping an eye on him. And basically, we prevented the atrial fibrillation with a combination of drugs. That's a very interesting combination. It's off-label. And we also told the patient he's going to have a heart attack and we're going to rescue him. We have the navigator who's going to follow him around. And indeed, he went through the surgery fine. And then they saw him to send him home with the daughter and the phone numbers and everything, and said, if you have chest pain, you be sure to call. And his daughter dropped him off, and he's having lunch, and all of a sudden he gets this chest discomfort, and he calls his daughter and says, I'm having the chest pain Dr. Harrison said I was going to get. Meanwhile, we're sitting around the cath lab twirling some catheters around waiting for him. And so as it turned out, he came back to the hospital. He got a workup. His troponin was negative, his EKG no change. CT of the chest with chest CT showed no PE. He had some little anterior wall, which points to the LAD, and then he started blipping troponin. Somebody forgot his propafenone. He went into atrial fib, and then he's put on these drugs and to the cath lab. And so basically, this is what we saw when we're looking at his plaque before he went to surgery. And this is what it shows in the cath lab, where it's not very distinct. See how blurred this is in here? And so that should be very distinct. And so basically when you get a lot of platelets going in there and it starts getting mushy with clot, that's what it looks like. And so, but it looks a lot better now cosmetically. Now that he's got a stent and the fire drill is over. But we were very circumspect, and we certainly didn't give him anything that was going to cause him to bleed into his hip. And we were very circumspect also in saving his heart. And so we'll show you that he does not have any scar tissue in the heart muscle at all with late gadolinium enhancement with MRI. And he has normal contractility. And his hip's okay too. And so, one, we prevented the heart attack by aborting it in the middle of it with close surveillance. And two, we prevented the atrial fibrillation with dronedrone and ranolazine, even perioperatively, giving that with sips of water before his surgery. And here he is, and he's given us permission to show his picture here. And he says, I'm very happy that I had my hip surgery and also grateful that Dr. Harrison and Sharon prevented me from getting atrial fibrillation, but also knew I'd get a heart attack, which they anticipated and prevented damage to my heart and my hip. Total cost of $28,000. Somebody who has a heart attack as a surprise, at Tampa General, basically $40,000. So we did save some money, and we could cut that back in predictability. Unfortunately, I was out of town when he had his surgery, and the doctors didn't really think he's going to have a heart attack. And so if we had some real believers, he would have gone to the cath lab immediately instead of having horsed around for a while and got some blood tests and things. So this shows you the cost run up. If you say 18,000 here, probably not that low, in New York, but 18,000 here, and then we got atrial flutter will take you another 20,000 or so. Predicted heart attack will 28,000, and then a patient that has a surprise heart attack 40,000, and then a patient after a silent heart attack and comes back with a congestive heart failure will be about 60,000. So there's a lot of cost overrun and outliers. And this is our summary stuff that we've talked about before and sort of putting it all together on one slide. And this is our pilot project. And we're going to say, hey, before bundling, which is 72 hours before surgery, we're going to do these things. Okay, this is our little Zio, little Band-Aid-like recorder, and we got a CT, and we got echo, and we look at the carotids, look at the heart. And so very simple, keep it under $1,000, just barely, but keep it under $1,000. And we're going to look for atrial fibrillation. When we find that, we're going to put you on some ranolazine and dronedarone combination that seems to work pretty well. And we're going to avoid anticoagulation if you go atrial fib. We're just going to convert you quickly before 12 hours or maybe before 28 hours, whichever way we can do. And we've got ways of doing that, and we've got lots of information on that, and we're going to prevent this cost overrun. So let's look and see. We started this November 1st. And basically, we've got the echo, the carotid, cardiac CT, and here's how we do it. We can do it all one day. You come over, and we have 4 or 5 patients here, and take care of that real quickly in our clinic. Got an echo tech, and that comes over pretty fast. Fill these things out. It's a 10-minute test to get a coronary CT, and then bring it back on a disc, and we look it over. We put all that together, and then we decide if you're at risk of having atrial fib, and if we want to monitor you, prevent that. And then here's the data we fill out on a sheet, and the anesthesiologists love this because it gives a lot of information that they're looking for. There's another way of looking at it, and here's our estimated risk is going to be by the Tampa Bay risk score. We have our own score, and we say it's high, low, medium, usually low, and basically using this information and this information, and that's basically where we come to. Even if we have normal studies and there's low risk, that's very helpful, because if somebody calls a cardiologist, they're going to sell a cardiology 6-pack, which is usually EKG and echo and history and physical and nuclear scan and a cardiac cath, and all that stuff is the $7,000 value. And so you want, if we have all this worked up, nobody's going to grab this patient and go do those tests, because we know if they have any coronary disease or not. And here's a group of the patients that we're looking at, and we'll show you our first 50 or so patients. And so green light means that the patient's stent is patent, or the bypasses are open, or there's a low score on coronary artery disease. And the low score means that there's just some calcific nodules that are very focal, and there's no vulnerable plaque or no active plaque, no risky plaque. And then hypertension is something very important. Atrial fibrillation is very important. And left ventricular hypertrophy, which leads to atrial fibrillation, is very important. It shows that the hypertension has not been adequately controlled. And we'd like it to be controlled when you have your surgery perioperatively. And so you can see what some of these things look like and what some of the things that we did. Here's, we discovered hypertension in somebody that's newly discovered, and we put them on antihypertensive medications. And we found somebody with paroxysmal atrial fibrillation. We put them on ranolazine and dronedarone, and got control of that. And you can see the ones that we picked up that were new, that nobody knew about that. And some people over 90, we don't want to give them the routine meds. And somebody we picked up with some adriamycin exposure in the past and some lung problems and so on and so forth. And so you can see what we're looking at. And for the most part, we've got a green light on the patients that we're investigating. The atrial fibs that's chronic, basically, we can't do a CT scan on, so you didn't see that. But we found somebody that was a CHAD-RAD score of 0 and didn't need Coumadin, and we stopped his Coumadin for sure, both preoperative and postoperatively. And so you can do interventions, and then we can add them all up and show you what this resulted in. But you can see here we found a lady that has a thoracic aortic aneurysm, which was a good discovery for her. We found pneumonia in this guy's chest. We found a hilar lesion, which was also pneumonia in this guy's chest. And so there's a lot of stuff that we're picking up that needs some treatment that we jumped on. And so let's look and see how this how it turned out in 56 patients on our pilot project. And so here we had 52% had hypertension, of which 4 had undiagnosed hypertension that was inferred by left ventricular hypertrophy. And we had left ventricular hypertrophy in 37% of all patients, and 72% of the patients with hypertension had LVH, which meant that they were never adequately treated. They were only on one drug. Atrial fibrillation, here's 11%. Chronic atrial fibrillation, 12%. So a total of 23% of patients. That's amazing. 23% of atrial fibrillation in our little group. Most of them, look at this. This is a surprise. I mean, we were told everybody has coronary artery disease. Well, looky here, 41 out of 42, 98% don't have any significant coronary artery disease, or if they do, they have patent stents and patent bypasses. So we only have 2% that are at risk. Action taken in 3% of the patients. And then I got this little diagram to show you what happens. And what's happening down here is we got hypertension, LVH, diastolic dysfunction, left atrial enlargement, and then we got left ventricular fibrosis, paroxysmal atrial fib, and chronic atrial fib. And then I think that's the cause of the CVAs that patients are having perioperatively. And I can tell you that from my experience yesterday, because the lady came in yesterday and we were evaluating her to get her hip, and she had some tiny little CVAs the week before, historically, and we did an MRI of her brain and found 3 little lesions, and we found she was having atrial fibrillation and never been diagnosed. She had TIAs in 2008, 2012, 2017, so she was having this little shower once in a while over a couple of years. And it would have been blamed on the surgeries. Certainly they would have been in the bundle, having a stroke post-op. And so we had to cancel her surgery, get her anticoagulated, keep her out of atrial fib, and then get her ready for surgery again. And so that's pretty much, here's the distribution in terms of coronary artery disease on this little group of 56 patients. And you can see most of them don't have much of anything that's at risk, except here's our guy who had the heart attack. And then here's somebody who had some coronary artery disease, and somebody stumbled in an abnormal EKG that was a false positive. Then they did a nuclear scan that was a false positive. Then they stumbled on some lesions in the cath, and they fixed the easy ones. They cherry-picked the easy ones and left a chronic total occlusion, which was causing ischemia. They left that one. But anyway, that wasn't a problem because it's not ulcerated. So a patient went through surgery and did fine. And so here's cost potential. And we keep reevaluating this and changing this as we go on. So we're thinking about how much we're spending, and the spending is outside the bundle, so we didn't highlight that. And then what we may be spending inside the bundle from these risks. And then we took it and divided by 100 patients, and then we said, let's just divide that by a third. And we came out with a conservative assumption that we may be saving somewhere in the $2,200 range if we can do all this right. And so that's kind of what we wanted to tell you about today. And we were hoping that we can go on in the future to do something like a registry together. We're hoping to do some platelet research with Jeff Berger's lab in terms of platelets being just as important as plaque ulcers. We're hoping to rewrite the guidelines and best practice with talented orthopedists and orthopedic researchers like you guys. And so this is our team for private cores. There's Jarrett, he's on the call. And over here is Beaumont, our faithful dog. And this is Captain Cardiac. And coming over here, we've got our orthopedist, fine-looking group, but there's more. And so this is our team. And we want to thank you for coming to our presentation today. And so be very interested in feedback, comments, and what you guys think. And perhaps we can do some future interaction with more of your group. Bill.
Sounds good, Eric. Did Jim Slover make it on the call?
No, Jim Slover didn't make it. I don't know what happened to Jim. We tried to recruit him. We sent him lots of messages, and people called him, but he didn't make it.
Okay, sorry about that. It was my expectation he would be on with us.
Yeah. So
Maybe he's having the
where would you like to
maybe
go
he's
from here, Bill?
so I am very interested. I think that we want to help you. I guess one of my questions is, so you guys have this new company that you're building, right?
Yes, sir.
And this company, I guess I take it's built on the power, the predictive power of CCTA.
That's correct.
And how old is this technology? How long has CCTA been available in the form that you're using it in?
I've been doing this since 2004 in this form. 5,000 patients.
So, I recently got a new NYU primary care physician, Steve Lamb, and he sent me for something called a calcium score. And I went in and I had a CT scan of my chest. And I think all they did was calculate the amount of calcium that they found in my chest, maybe specifically in the heart. Is this something similar, or is that totally different?
That's basically similar, but not enough data. And so basically, I've got a whole lecture on why you don't do calcium scoring and why you go ahead and inject the dye and make the picture. So you don't see inside the vessel, all you see is the calcium that exists there, and you add it up. And we can show you how much more definitive it is to just inject the dye and make the rest of the picture. And we've got that
Right.
priced at $199 for patient. The calcium score is $99. It's $199 for the total study. And then basically, then we can actually calculate some risk that's much more fundamental than the calcium score. Because the calcium score was, you got so much calcium, this is your risk, 20% or something, or this is risk you have heart disease or you have blockages. And we can tell you exactly, what your risk is and whether it's even worth containing or not. We have people who have some calcium and it doesn't mean anything. We have calcium scores of 4,000 that can bike across the state of Arizona. And we have calcium scores of 3 who are in big trouble and are going to rupture a plaque. And so it doesn't tell you enough, And so we have a lot of calcium score people who have been doctors who bet their career on it, who are basically calling me up and saying, hey, can I come over and train with you? I want to look at these plaques inside the arteries, And so those guys are bailing out of the ship after 15 years. So come down here when it gets to be snowy up there and freezing. Come down here and we'll give you a complete study and go over it together and we'll teach you about this.
So,
well, what's your calcium?
we're in. I had a calcium score of 0, but now I'm not too proud of that.
Well, you only have a 5% chance of still having a problem there with a calcium score of 0. So that's not bad.
With my luck, it probably got a plaque.
So where do you want to go from here, Bill? Where do you want to go from here?
We want to learn more about it. We want to find out, what's in it for NYU Langone and Rich Iorio's adult reconstruction division. We're interested in research projects. We're interested in the consensus statement with the academy, which there's a very specific process that they use at the academy for these guidelines. Are you familiar with it?
The process, no. But you and Rich could advise us there, and we'll take it together. Okay.
Yeah. I'm not sure it would be as easy as this. We come up with something and they adopt it, because it's a very distinct process. And that's probably why, it gets so complicated with 183 pages on the other side.
We've got to go. We've got to go on to our next international meeting with our Polish friends, who are going to present. If you
Yeah.
want to come to that, that's another login. But we got to move on with
Okay.
that. And then why don't you come up with you and Dan get together and come up with something for us where you'd like to move on to the next step. How about that? Because we need to ally with a major university that's in terms of doing some research and moving forward. Okay.
All right. Sounds good, Eric. We'll talk soon.
Okay. Bye-bye.
Yep. Thank you, Eric.
Thank you, everybody. Jared, Delina, Dan. Thanks, everybody. Bill.
Thank you.
Have a good day, guys.
Appreciate the call.
Okay. Take care.
You too.